Welcome to Forum 360 with its global outlook and local view. I'm Ardith Keck. Is there anyone out there who has not fought the battle with weight? It is a battle that most Americans wage constantly. So today we have two experts in that battle. They represent the Summa Health Weight Management Program. Dr. Adrienne Dan is co-director and a bariatric surgeon for the Weight Management Institute at Summa Health. And Dr. Vivek Mathur is a medical weight management physician, Weight Management Institute, Summa Health. So let's learn all about managing our weight. Dr. Dan, can anyone come into the Weight Management Institute?
Well, Ardith, first I want to thank you for having us today. And the answer to that is yes. Anyone struggling with obesity or overweight, which is also a known condition, can come see us at the Weight Management Institute, where we offer the entire spectrum of treatments for obesity, overweight, and the associated conditions.
I only have about 30 pounds to lose. Can I come?
Absolutely. As I said, anyone who struggles in any way or wishes to manage their weight, there's so much knowledge that can be imparted by our medical doctors, our behavioral health colleagues, and in that situation, you would not be a candidate for surgery, but you could certainly work with a dietitian, with a psychologist, with a medical doctor to help address that.
How overweight does one have to be to qualify for bariatric surgery?
So that's something that's actually changed in the last few years, and the reason it's changed is because of the new evidence and the literature that we have amassed over the last 20 to 25 years, looking at who would benefit from bariatric surgery. Right now, in a nutshell, if your BMI is over 30 and you have type 2 diabetes, you qualify. If your BMI is over 35, regardless of any other conditions, you qualify. And in some populations, like the South Asian population, with diabetes, it's as low as 27.5 BMI. And BMI is a way to relate your weight to your height. There's a calculation that is pretty easy to do.
That doesn't sound like it's very overweight.
It doesn't, because it has become a more commonplace. You know, obesity and overweight are the most prevalent or most common chronic diseases in America. And at those levels of weight or body mass index, you begin seeing complications related to obesity, such as diabetes, hypertension, osteoarthritis, wear and tear on the knees, the hips, gastroesophageal reflux, sleep apnea, and the list goes on to about 250 conditions that in some way have been linked to the disease of obesity.
Please tell us what you do in bariatric surgery.
So the most important thing, we sit down and build a rapport with the patient. We try to build that trust, that understanding, and explain to them how bariatric surgery, or if they're a candidate, how an operation could benefit their health. What we look at is their increase in longevity. Many people add years to their lives. They can cut down cancer risk. They can cut down on the risk of a heart attack, a stroke, kidney failure, etc., and prevent many of those conditions while resolving some of their current conditions that I mentioned earlier. We like to discuss the benefits. We like to discuss the risks, the expectations, and the details of the process that leads up to surgery. And then eventually we perform what are very safe and effective and durable operations. It's important for people to realize just how safe the procedures that we do are. They are safer statistically than a gallbladder operation or a hysterectomy, a knee replacement, things that we see people get quite commonly.
Mm-hmm. And what about the after effects?
Well, I think, and I say this tongue-in-cheek because people ask me this all the time, the after effects are pretty darn awesome, right? The average person adds about 6 years to their life. The average diabetic adds about 10 years to their lifespan, not to mention they improve the quality of life of every one of those days, plus the extra time. But I do know what you mean. Sometimes people worry about the potential side effects related to surgery, and thankfully they're very, very few and far between. Everyone is looking for that catch. Am I going to have a poor quality of life? Am I not going to be able to eat? Am I not going to be able to order off the menu or sit down for dinner with my family? That's just not the norm. That's just not what we see. Do we see once in a while that someone may have some vomiting that can be fixed with whatever, figuring out whatever the problem is and fixing it? Yes, but no more than we see with other therapies for obesity, such as medications. They themselves have a lot of long-term issues that could affect the patients. And in a nutshell, surgery is extremely safe, and long-term side effects, other than having to take some vitamins, they're mostly positive.
Okay, I'm ready. Dr. Mather, if I have 50 pounds to lose and I come in, what steps do I take? Or what steps do you take?
Sure. So on the non-surgical side, we really focus on behavioral modifications and lifestyle changes. So initially, we'll talk to each individual patient about their current dietary plan, their habits, what time are their meals or their snacks, what beverages are they drinking, what are they eating with what, so like their food pairings. And we want to try to set up a good meal plan to try to help with sustainable weight loss. So our goal is for long-term weight loss and to avoid yo-yoing. We really want to avoid the ups and downs of weight.
Do you use medication like Wegovy or something like that?
So we absolutely can discuss anti-obesity medications. I would say the first step is to make sure a patient is comfortable with using a medication. And then we would discuss, do we want to go the route of an injectable medicine like Wegovy you mentioned, or Zepbound, or a pill medicine if the patient's more comfortable with that. In general, the injectables, over the medical studies or medical trials they've done, they've shown a higher weight loss than the pill medicines. But I would say another reality of the situation is the cost. So sometimes the medications are cost prohibitive, and so we would try to work with patients on what's going to be best for the patient, and what's paramount is what is going to be safest. So we don't, or we want to avoid medication interactions and look at a patient's medical history to make sure the medications are safe, and again, for long-term weight loss.
And you talk about not regaining the weight once you've lost it.
Absolutely. I mean, obesity is such a complex, chronic, and stubborn disease. So do some people regain weight? Yes. Does everyone regain weight? No. And often people who regain weight, it may be a small percentage. But that's when we want to see patients back in the office. So even if someone's gained 10 pounds or even 5 pounds, we want folks to come back and see us, because it may be as simple as changing a meal timing or maybe a medication dose. So we want to help support patients through that.
Okay. How many pounds would you say I can lose in what length of time?
So in general, we like to tell folks that a good healthy weight loss is about 0.5 pound to 1.5 pounds a week. So in general, about 1 pound a week. So we don't want to exceed that too much, because then I would start getting worried about, is the patient's meal plan or their exercise plan, is that something sustainable? We want this to be lifelong. And then again, we want to avoid a patient losing a lot quickly and then regaining the weight. And that would kind of, be counterproductive of what we want to do.
Does this cost a lot?
So it depends. In terms of, in terms of medication specifically, some medicines can...
Some of those, I know.
Some of those medications can be extremely expensive without insurance coverage. We would always try to make sure that the medications are covered. I would say the pill medicines are much more affordable, although, again, they would cause a lower weight loss. And then if the injectables aren't covered, we could talk about some programs through the pharmaceutical company, if that would be an option to help lower price. So really it's individualized per patient what our care plan would be. And not everybody has to be on a medicine.
Today I'm talking with Dr. Adrian Dan, who is co-director and a bariatric surgeon with the Weight Management Institute at Summa Health, and Dr. Vivek Mathur, who is a medical weight management physician with the Weight Management Institute at Summa Health. And we're talking about losing weight. Obviously, many people need to lose some weight. How does the medicine I take do anything else but take my appetite away?
So the injectable medicines are truly revolutionary medicines. They work in the GI tract to slow down how fast the food goes through the GI system, so it does help with keeping patients full longer. But these medicines also work in the pancreas, the liver, and even the brain to help with cravings and appetite. So they work in many different ways.
But they're relatively safe.
So again, I would go through all the side effects of these medications. I will say that in general, yes, they are safe, but we would want to make sure that we go through all the potential side effects, make sure there are no medication interactions. So we wouldn't put these every patient on these medicines, only the ones that are good candidates for it.
Does insurance pay for bariatric surgery?
So right now, state-sponsored insurance does Medicaid and Medicare products in the state of Ohio. And for our patients who have private insurance, about 50% of plans will pay for that.
Mm-hmm. That's pretty effective.
Yeah, we have improved that over the years through advocacy for our patients.
And you sometimes get payment for these drugs?
So it's a bit less predictable, and that's why we often just go ahead and prescribe the medicine to see if a patient-specific insurance plan will cover it. And then in terms of the pill medicines, most of those are covered in general, but yeah, it can be variable with the injectables.
What is known about weight gain? Is there a lot that we know? Is it just eating more calories than you use?
So we know that it's a very complex multifactorial disease. Dr. Mathur mentioned how frustrating obesity can be for patients and clinicians to deal with. I'm a little more aggressive at that. I call it SOB because it really is. It's very difficult to control obesity long term, especially when genetics comprise about 70% of the reason that adults are obese. With some genetic defects, you could see severe obesity in childhood. Those are single defects. But with the type of obesity that we see, In the adult population, a lot of it is related to a host of genes, many of which can be turned on by our environment. For example, these are genes that helped our ancestors make it through the winter by storing large amounts of energy. They were very useful back then, but now, with the amount of calories and food and provisions that we have around all the time, they're no longer necessary, and we can still store that food, and that leads to obesity.
So our bodies just haven't changed to accommodate.
Our bodies are not used to the type of refined foods that we ingest these days. And I want to go back to the medications for a minute, if that's okay. You know, as a surgeon, I'm really happy about the fact that we have some very effective medication, because we look at it as a spectrum of treatment, treating with diet and exercise programs, behavioral therapy, medications, and ultimately, for the most severe cases, surgery. To some degree, there may be risks with anything, minor risks, but the medications are safe, the operations are very safe and very effective. What's not safe is not treating your obesity, right? When someone treats their obesity with surgery, in 8 years they decrease their chance of a heart attack by 30-some%, stroke by 30-some%. In women, they decrease their chance of cancer by 50%. In half. I mean, that should be on every billboard out there. And they decrease their mortality by 41% at 8 years. So for every 13 operations that I do, one person would not have been alive at 8 years. And the same goes for the medications. Treating your obesity with these medications, although there may be some minor side effects, that's great, and not treating your obesity is not safe. That's, I think, the take-home point that I would like our viewers to get.
I notice the difference. I've gained a little weight. I'm fairly old, and I've gained a little weight as a result of aging, and my body just not accommodating that well. And I can tell my breathing is different. Whoops. And I'm sure it's the weight and the fact that, excuse me, I have gained this weight. Do you know of any other drugs that are being developed just for weight loss?
So there are definitely a lot of trials for new medications. They're trying to, even combine some different medications and different mechanisms of action, so to speak, to try to get them to be even more effective. So there are definitely medications in the pipeline, and also they're trying to develop more pill medicine so they can be easier to take rather than an injectable that's weekly or daily. So absolutely, there are many medicines that are being studied.
Some of these medications are incredibly promising. There's proteins called incretins, GLP-1, like the drugs that were mentioned, GIP, glucagon, and even a polypeptide called amylin. And there's a lot of medications in the pipeline looking at utilizing these proteins, synthetic proteins, to improve overall health, decrease weight, improve diabetes. But I also want to mention that all these are proteins that your body makes naturally. And the way that these proteins were identified is by studying what happens in patients who undergo bariatric surgery. So these can be very costly over the long term, whereas bariatric surgery can actually have your own body make them naturally and in the amounts that are necessary, becoming really over the long term the best return on investment for a patient or an insurance company in order to be able to manage obesity long term. And the other thing I want to mention is the concept and the idea that's still developing that obesity should not be treated with one or the other. It will definitely need to be treated with medication, and in some patients with surgery, and also with behavioral therapy. So very much like we treat cancer with radiation and chemotherapy and surgery, that concept of multimodal therapy to best provide a plan for a patient is what we need to focus on. And that's the future of obesity.
And a weight management program is an excellent idea.
Well, that underscores the importance of a comprehensive program like ours. I'm really proud of our surgical arm, and I can't say enough good things about our medical arms. They're really the envy of all my colleagues who I discuss our obesity medicine department with. They are just in awe of what I have in terms of collaboration and the ability to work with some fantastic medical doctors and behavioral therapists, psychologists who help the patient manage the disease from every possible facet.
And behavioral management people would be invaluable, because I find that I don't exercise as much as I should.
Invaluable and frankly underutilized. That we need to consider more of the amazing contributions that they can make to treat this disease.
Binge eating disorder, night eating syndrome, emotional eating, those can all contribute so much to obesity, and often we need to get our psychology colleagues involved to help with that. So definitely something important.
That's why it's Weight Management Institute rather than Weight Loss
Correct.
Institute.
That's exactly right.
Yeah.
Because we want the sustainable weight loss, but we want to avoid or even prevent or improve these metabolic diseases like Dr. Dan was saying, like diabetes and hypertension, sleep apnea.
Important, very important. Okay, when I come into the Weight Management Institute, I assume I call for an appointment.
Yes, you can, if I'm not mistaken, you can be referred by your doctor or self-referral.
Okay, so I make an appointment, and then what happens?
So often you'll talk to the new patient team that discusses do we want to start with non-surgical or surgical? But there's so much overlap between the two programs. So for example, on our side we'll see patients that Dr. Dan is going to take to surgery several times before surgery. And then after surgery, that patient will follow up with Dr. Dan and his team, and then they come back to us at 18 months for lifelong follow-up. And then similarly, non-surgical patients, if we're hitting some roadblocks and are reaching our goals, we may ask a patient to talk to Dr. Dan and his team about surgery. So we'll start with either surgical or non-surgical. We'll talk about dietary plans, medications if those are deemed appropriate. We have support from dietitians. We have a monthly virtual exercise 101 class that helps patients with setting up an exercise program. We have the psychologist support. We have amazing nurses who are great patient advocates, and then we work with an amazing team of surgeons.
Okay. I have taken Wegovy, and it totally turns you off to food. And I know that it's basically a drug for diabetes, but it has shown good results for weight loss.
Correct.
Is that the case with almost all the drugs now? That they're basically diabetes drugs, but have shown?
So in that particular class of medications, the GLP-1 receptor agonists, yes, we have discovered those and encountered them in studying how bariatric surgery works. and then they were able to be placed in an injectable medication and now sometimes in a pill form. And initially they were utilized for diabetes care, but because of their side effect of weight loss also they're being used for that. So in that particular category, yes, but there are other medications that are in the pipeline that may not be exactly the same mechanism of action.
Okay. Thank you, Dr. Dan and Dr. Mather, for your help today in learning more about weight and weight loss. We've learned a lot, and we appreciate your help. Thank you also to our audience for tuning in. This is Ardith Keck for Forum 360.
Forum 360 is brought to you by John S. and James L. Knight Foundation, the Akron Community Foundation, Hudson Community Television, the Rubber City Radio Group, Shaw Jewish Community Center of Akron, Blue Green, Electric Impulse Communications, and Forum 360 supporters.